So, the way.
Hi, good afternoon, everyone, and thank you so much for having me joining the Peanuts lecture series. So today I'm going to talk about the pediatric leukocoria. I would like to highlight a couple things that we commonly see in like a practice. So nothing to disclose. So I would like to start with the take-home point for the patient with the leukocoria. The take-home point is when we have the patient pediatric leukocoria, we need to think about retinoblastoma until proof otherwise. And I would like to start with the 6 patient on this screen. And I mean, if you have a pen and paper, you can try to write the diagnosis down on each patient on what do you think on each patient has like a patient number 1, I give you the post-contrast T1 and SWI. Patient number 2, I give you the T2 3D and ADC image. Patient number 3, I give you the axial T2 and also post-contrast T1. Number 4, T2 and also post-contrast T1. Patient number 5, I give you the orbit image on the axial T2 and also the axial brain T2. And patient number 6, I give you the axial T2 and also the axial brain flare images. So if you can write down your diagnosis on each patient, that would be great. And we can have the answers at the end of the lectures. Okay, so the outline for today that I'm going to talk about, I will start with the optimization of the protocol and sequence on when we have the patient with leukocoria, what we should do. And then I'm going to talk about the normal group anatomy and try to differentiate between retinal and colloidal detachment. And I will walk you through the imaging checklist for the most common diagnosis for the patient with leukocoria. For the tumor that we have the diagnosis of retinoblastoma, the patient that has a retinal detachment that can cause leukocoria, including cold disease, retinopathy of the prematurity, and also some medial opacification like PHPV or persistent hyperplastic primary vitreous. And right now we just call it as a PFV, like a persistent fetal vasculature. So for the optimizing of the protocol and sequence, we're going to talk about the role of imaging. So we have like too many options in our hands. We have the MRI, which is the important modality for the workup, differential diagnosis, and also for further management. Ultrasound is another modality that we can do, which is inexpensive, non-invasive. And I do believe that majority of the ultrasound of the orbits right now, the ophthalmologists are doing it by themselves. And then we also have the CT that we are almost always talking about the CT that is good for the calcification detection. However, it's also increased the radiation risk to the patient. So in terms of the leukocoria, I think the main modality that we have to do and more like the first line right now and gold standard is MRI, which is we can use it for the initial workup. We can use it to detect the secondary lesions, access for the extension or metastasis, and also the follow-up study. So for our protocol at Riley Children's Hospital, we normally do brain and orbits together every time. So the reason is because we want to look for any intracranial metastasis. For retinoblastoma, we're checking for pineal and suprasellar metastasis. And also we want to look for associated brain findings that can happen in the setting of the patient with leukocoria, such as for the retinopathy of the prematurity, that we look for the sequelae of the preterm baby, such as periventricular leukomalacia or intraventricular hemorrhage, or like a reperfusion injuries. And for the patients with a retinal astrocytoma hamartoma, which usually associated with patients with the history of tuberous sclerosis or NF1. So we can use the brain finding to help us with the diagnosis of the leukocoria. So in terms of the standard MRI orbit sequence, normally we have the axial and coronal T1 that we normally use it for the hemorrhage or high proteinaceous material. We have the axial and coronal T2 that we can check for the growth on the size, shape, and contour. We have the axial GI and SWI checking for hemorrhage or calcification. And we do love the DWI because we can use this one for tumor grading. And we have the additional sequence. We almost always doing the high resolution T2 3D image that get the slide thickness down to 0.5 or 1 millimeter, and we do the corona and sagittary formats. We use this one to increase the sensitivity to detect small retinal lesions or detail of the optic disc, like flattening or bulging, and also checking for any like optic nerve involvement or extension. Sometimes we do add the small field of view SWI for the improve the image quality and sensitivity for the hemorrhage and calcification. And also we do the small field of view for the DWI for the tumor grading if we see like a retinal lesions like a retinoblastoma. So this is the image that I show you for the high resolution T2 3D that you can see the detail of the group very well. You can see the detail of the optic disc, optic nerve, and also the optic nerve sheath. For the SWI that you can see the calcification and also hemorrhage extension of the optic nerve. And also on the DWI image that you can see restricted diffusion of the lesions in the posterior group. So in terms of the normal anatomy of the group, I have the drawing picture from the Radiopedia to show you the drawing picture. And I also have the axial T1 image of the orbits here that I zoom it up. So there is three things that I want to show you in this image is the layer of the retina, colloid, and sclera. So when you look closely on the T1 image, you can see the black line here on the T1. So this is the first layer of the retina. And then you see like a bright signal here that is a layer of the colloid. And the most outer layer that show the black signal again, that is a sclera. So it's more like the sandwich that you can see retina, colloid, and sclera together. And on the T2 image, you cannot see those things very well, but you can see the contour of the posterior group better and also the optic nerve. So in terms of the differentiation between the retinal detachment and choroidal detachment, so also this is a drawing picture that I think is very helpful from the StatDX that trying to show you the differentiate between the retinal detachment and choroidal detachment, because normally for the retinal detachment on the left hand, we normally see like a V-shaped appearance that have the apex at the optic disc compared to the choroidal detachment that normally usually have like the parallel line along the lateral groups and does not have the apex at the optic disc. So in terms of the imaging checklist, when you have the patient with the leukocoria, first thing is retinoblastoma until proof otherwise, because it's about 60% of the patient with leukocoria has a retinoblastoma. And then the next step is you need to check on the size of the group. If it's bigger or smaller or normal size of the group. Because when you see like the group is relatively normal or a little bit bigger, you need to think about retinoblastoma. But if you see like the small size of the group or like a deformity malformation, it can be cold disease or retinopathy of the prematurity or PHPV. And then you check for any like a retinal detachment or any like a hemorrhage and any underlying mass. So which means when you see any mass, you need to check for any calcification or restricted diffusion to call high-grade tumor. So I have the patient's number one here. This is the scan, CT scan, like many years ago, like 15 years ago when I was a fellow. So during that time, we normally like start with the CT, but right now we start with the MRI. So during that time, this is a 3 years old with the left leukocoria and has the preseptal soft tissue swelling. So on this image, you can see that the left group is big compared to the right, and also some soft tissue density, mass with internal calcification. And when you look closely, there is enlargement of the left optic nerve compared to the right. And patient has a left proptosis. And we have the follow-up MRI that confirm the findings of the enlarge of the left group, also with the mass with the internal calcification. Also the optic nerve involvement with contrast enhancement, and also some intracorneal fat involvement that you can see fat reticulation within the intracorneal fat space. And on the mass itself, you can see the restricted diffusion of the mass itself and also the left optic nerve. So with the finding of restricted diffusion, this is suggestive of like a high-grade tumor. So it is a retinoblastoma. So which means I would like to give you a little bit background on the retinoblastoma, which is one of the most common ocular malignancy of childhood, 60%, and majority of the patient, more than 95%, present before 5 years of age. And unilateral about 60%, bilateral about 40%. And every time when you see this concerning for retinoblastoma, you need to check for like a trilateral or quadrilateral, and also like any like a contralateral lesions in the another groups, usually associated with the RB1 mutation. And when you see extraocular extension, this is a poor prognosis. And when you see like an involvement of the optic nerve, colloid or anterior chamber of the group, has a high chance to have like a metastasis. So on the CT, we almost always talk about like a mass with internal calcification, which about like a 90 to 95%. On the imaging checklist on the MRI, besides the lesions within that group, you need to check for any like extraocular extension to the optic nerve or to the intracorneal fat or also intracranial extension. And you also need to check for the contralateral, any additional lesions. So key imaging for the retinoblastoma, I love DWI. So when you see any mass in the orbits or head and neck, you should do the DWI to prove if that lesion is a high-grade tumor or not. We do the T2 3D to look for contralateral lesions and extracorneal extension, and also post-contrast brain for the additional lesions within the pineal or the suprasellar. So this is patient number 2 years old with the right leukocoria. So on the physical examination, there's concerning for like something in the right groups, which on these images confirm the findings that we see the lesions in the light group, some contrast enhancement, and also restricted diffusion. But our job are not done yet. So we need to check for contralateral lesions, and turn out that this patient also have another lesions on the left group. So turn out that this patient has a bilateral retinoblastoma. So this is our job, that we need to check on the bilateral on both sides of the group to see any additional lesions. Maybe because we are the one who can tell the clinician that, okay, you need to treat both eyes. So in summary, for the current protocol, if you're concerning for the retinoblastoma, we do brain and orbits, as I mentioned earlier. And also, we also add the MRA brain. The reason for the MRA brain that we added is because right now, the treatment options for the retinoblastoma, we can do intra-arterial chemotherapy, inject the chemo through the ophthalmic artery. So that's why we want to at least tell our neuro IR people about the origins of the ophthalmic arteries. It helps them to reduce the radiation dose when they are trying to find the origin and like a super select to that vessels. So this is the patient's number 3 that also present with the leukocoria. So on these images, you can see the abnormal finding is on the right group, that you can see some fluid collections posteriorly, and also like the right group is relatively small compared to the left. Also, we can see the retinal detachment that is a V-shaped appearance, has a apex at the optic disc. No definite underlying mass seen here, and very minimal and contrast enhancement may be along the retina. So this patient turned out to have a cold disease. So this is the exudative retinopathy that happened because of the abnormal retinal telangiectasia that affect the vascular development and cause like a leakiness of the vessels and has a subretinal or retinal fluid leak. So that's why it's more like some fluid accumulation that in the subretinal space usually happen in the patient less than 10 years old, usually unilateral, and the group usually normal or smaller size, because this is some like abnormal development. And we should not see any calcification or any underlying mass at all. So key imaging that, as I mentioned, leukocoria check the size of the group. This is a small to normal, has a subretinal exudate with a V-shaped retinal detachment, rarely see calcification, and normally just like a confined within the group, no extension beyond the group. Always differential diagnosis with the retinoblastoma or PHPV or ROP. This is the fourth patient, case number 4. So this is a newborn with leukocoria, and based on these images, you can see that the abnormal findings is on the right eye. So when you look closely, the right group is relatively small compared to the left. And then you don't really see the retinal detachment, no like a fluid at all, but there is like a linear stuff that show like a linear contrast enhancement that connect from the lens to the optic disc. So this patient turned out to have like the PHPV, or right now we call PFV, persistent fetal vessels, which is the congenital malformations due to inadequate development of the embryonic primary vitreous. So that's why we see the residual tissue in the vitreous chamber. So let's talk about the normal development that we can see here. So normally the development starting at the gestational age 7 weeks, and it usually regress at the 20 weeks and disappear at birth. So if that like a vessel, like a persistent, we call that things that hyaloid vessels, artery that has like within the crocret canals, and that form fibrous tissue posterior to the lens and extending to the optic disc. And this is more like the board exam questions. When you see this thing, the classic appearance that we call is Martini grass appearance. So I think like the key thing is for the PHPV or PFV is this is a leukocoria that happened on the first day of life, and patients normally have the microphthalmia. So key imaging, microphthalmia, and you see like the enhancing tissue from the posterior lens attached to the optic disc. That is the enhancement because of that is the hyaloid vessels, no calcification. Sometimes you can see a retinal hemorrhage or intraocular hemorrhage. And I mean, there is like no treatment options for this finding. It's very limited treatment options. Case number 5 that I have here is a newborn with a left leukocoria. So on these images, axial T2, you can see that patient has like the small left group with some dysplastic of the left lens, and also some like a triangular shape tissue here that extending probably like to the optic disc. And we cannot see the contrast enhancement very well here. But one thing that I want to draw to your attention is when you check on the optic nerve, it makes sense for the left optic nerve can be small because there is like some deformity of the left group. But why the right optic nerve is also small? It doesn't make any sense to have the normal group on the right optic, on the right group has a small optic nerve. And then since we have the images of the brain that we normally scan in this patient in the leukocoria, so the findings in the brain is when you look on the axial T2 of the brain, you see the ventricle, and there is an absence of the septum pellucidum. It's more like a single monoventricle. So this should raise your suspicion for one findings of the septo-optic dysplasia. So that's why you need to check on the midline structure, including the posterior pituitary bright spot. So luckily, this patient on the posterior pituitary bright spot, it is in the normal expected location. But in summary, so end up this patient has a PHPV and also with the septo-optic dysplasia spectrum. And we are the one who tell the clinician that, oh, besides the PHPV, they also have the septo-optic dysplasia that they can do some more workup. And this is the last case that I have here for the 6-year-old with the leukocoria. So not 6-year-old, 2 years old with the leukocoria. So when you look on these images, I give you only single images on the T2 that you can see the small left group with some like a hemorrhage, layering hemorrhage, and maybe some like a retinal detachment. And you have the brain MRI images, so the axial T2 flare and also the axial SWI. The first thing that you can see here on the axial T2 is you can see ventriculomegaly and also some polyventricular leukomalacia, flare hyperintensity, and also evacuodilatation of the lateral ventricles. Some susceptibility artifacts, some of them is in the along the ependymal lining of the lateral ventricle, and some of them also along the polyventricular white matter. So if we put two things together on these images, so this patient is a preterm baby, former 24 weeks prematurity, and on the oxygens. So with our finding, that has a ventriculomegaly, polyventricular leukomalacia, and also microhemorrhages from the reperfusion injury. So this patient has a retinopathy of the prematurity, which is a sequelae or maybe consequent or complication of the prematurity. So in this setting, patient it happened because it's more like the oxygen toxicity that affect the vascular proliferations in the group that happen in the preterm and that resulting in retinal detachment and also blindness. Couple times you have the CT, you can see some dystrophic calcifications. Since this is more like the systemic things, is usually bilateral and patient usually have like a symptomatic. So leukocoria retinal detachment, which is like a more advanced or less stage of the disease. And sometimes you can see the retrorental pseudomass or like a retinal detachment tissue. So the key images is, I think the key is like the history of the prematurity. You can see the small group, retinal detachment, and like some deformity of the groups, shallow, the anterior chamber, and calcification in the late disease process. So as I mentioned, this is the third time. So leukocoria retinoblastoma, to prove otherwise, about 60% of the patient with leukocoria has a retinoblastoma. First thing that you need to do is you need to check the size of the group. If it's normal to large size, it can be, you need to concerning for like a retinoblastoma and trying to find that things. For the small size or like a malformations, it can be other things. The most common could be like a cord disease, retinopathy of the prematurity, or PHPV, PFV. Oops. And then, yeah, and then you check for the retinal detachment or hemorrhage and any underlying mass. We give contrast. We do the DWI to check for any high-grade tumor like a retinoblastoma that normally show the restricted diffusions. So, and this is also the summary table that talk about the four most common things that we see on the imaging findings. So retinoblastoma is the main things: intraocular mass, calcification, normal to big group size, and also restricted diffusion. While other stuff usually have like a normal to small or like some deformity of the group and has like some calcification from like a dystrophic calcification or like a retinal hemorrhage. On the standard sequence that we are talking about, we're talking about T1 that we normally use it for the hemorrhage or hypertenosis material. T2, we normally use it for the group size, shape, and contour, SWI for hemorrhage or calcification, and DWI for tumor grading. High resolution T2 is a must. We need to have the high resolution T2 to check for any like a small contralateral lesions, checking for multicentric or multifocal lesions, any like a detail of the optic nerve or optic disc. I do recommend if you like do the scan check and you are not sure about the imaging findings, you can do like a small field of view on the SWI to improve the sensitivity to detect hemorrhage and calcification, and also small field of view of the DWI for the tumor grading. So for the answer on those 6 patients number 1 is like a left retinoblastoma with the optic nerve involvement and intracorneal involvement. Patient number 2 has a bilateral retinoblastoma. Patient number 3 has a cord disease. Number 4 has a PHPV, PFV, and number 5 has like a PHPV and also coincident with the septo-optic dysplasia. And patient number 6 has a retinopathy of the prematurity that you can see the sequelae of the prematurity for the ventriculomegaly, polyventricular leukomalacia. I also have 2 challenges case to show you. So this is case number 1. This is a 12-month-old with orbital swelling and leukocoria. So on these images, the thing that you can see here, we start with the axial T2 3D here. We have the axial T1. We have T1 post-contrast and also DW and ADC images. So first, I want to draw your attention to the right group that there is like some retinal detachment. We know this is a retinal detachment because it's like go to the optic disc, more like the V shape, a little bit hyperdense fluid here. So maybe like some exudative fluid, no restricted diffusion at all, no definite contrast enhancement for the underlying mass. So on the right orbit, it's likely to be like a cord disease, right? But however, when you look closely on this post-contrast T1 image, there is some abnormal finding at the scalp base and the bone here. That is more like a diffuse thickening and has an enhancement of that bone. So what happened to this patient? What is the most common when you see like a bone findings in like a very young patient? We normally have the differential diagnosis of like a leukemia, lymphoma, and also neuroblastoma metastasis. So this is just an unlucky patient that has like two things happen together. So one is a cold disease, and another one has like this patient has a neuroblastoma metastasis. And this is a challenging case number 2. 19-month-old boy with a right esotropia, ptosis, and orbital cellulitis, and has a prior history of retinal mass. So from like an outside hospital, and the ophthalmologist did some like a physical examination and just sent it to us to confirm the findings. So first thing that you can see here on the right orbit, so there is some like a plaque-like tissue at the optic disc. That's not, I mean, this is a T1 pre-contrast and also post-contrast. It's like a debatable, maybe subtle contrast enhancement, but not that much. And when you have the DWI images, it's maybe some restricted diffusion, a little bit of restricted diffusion. But on the physician note, they said like this patient has like this lesion for a while and just like a transfer to here for the follow-up study for the continue of care. So I think this patient is going to be challenging if we don't have the clinical information or physical examination from the ophthalmologist. We might, I think it's fair enough to call possible retinoblastoma, but with the clinical note and the physical examination, endoscopic, fundoscopic exam for the ordering physician, this turned out to be retinal astrocytic hematoma or hematoma of the retina, which I think like the key imaging findings here is this is a benign tumor, benign malformation of the nerve fiber layer of the retina. And I think this is the reason that we should do the brain images, because this hematoma of the retina usually seen in the patient with tuberous sclerosis up to 50%. And 25% of these tumors are bilateral. But I mean, for this patient, we did a brain scan, but there is no another associated brain findings to call tuberous sclerosis or NF1. But I think this is a good teaching point that sometimes without the clinical history, it's going to be very challenging to tell exactly what it is. But with the clinical history, it can help you. And if you see any associated finding in the brain, that is also very helpful. So sometimes these lesions can be calcified, but we should not see any like a necrosis or hemorrhage. And I think one thing that can help you is more like the plaque-like appearance that does not grow toward the vitreous humor, that help you differentiate diagnosis from the retinoblastoma. It's more like a plaque-like go along the maybe like an optic disc or the posterior globe. So in summary, I use only 30 minutes. So in summary, for the Leukocoria retinoblastoma, until proof otherwise, and we normally do brain and orbits together, checking for metastasis, intracranial extension, or any other associated findings. High resolution T2 3D is a must. I highly recommend this one for the detect multifocal or multicentric lesions. DWI and ADC is a must too for like any tumor, any lesions, any like a mass to help with the tumor grading. So I think this is more like the summary when I look on this one, and I try to put the age group with the diagnosis for the four most common diagnosis for the Leukocoria. So for the PHPV or PFV, this is more like the disease of the newborn. We always talking about this one as Leukocoria at the first day of life or during the newborn period. Retinoblastoma is one of the most common. 60% of the leukocoria usually happen less than 5 years old, but majority maybe like 1 to 3 years old. For the another diagnosis for the retinopathy of the prematurity that usually happen after you usually see like a patient usually asymptomatic, and we normally have the patient maybe after 1 year of age, because this is more like a sequelae or complication of the oxygen treatment toxicity from the prematurity. And for cold disease, you can see like at any age, but the peak usually about like 6 to 9 years of age. I think that's it that I have. Oh, sorry that I spent time only 30 minutes. And yeah, it's so fast. And if you don't know, I have like if you guys love Thai food, so I'm hosting the workshop in Thailand for the pediatric neuro workshop. So if you want to have like an authentic Thai food with some education for like a peds neuro imaging, so you are welcome to join the workshop in Thailand in August, and with a couple team member from Riley Children's Hospital joining me over there. Thank you so much.
That's awesome. Thank you so much. That was great. It wasn't too short. It was definitely yeah, very well, you know, very well done. Something that's definitely a difficult topic sometimes to differentiate some of these. And I'd love to come to Thailand. That'd be awesome.
Yeah, welcome. Yeah, authentic Thai food.
Oh my God, sounds great. Yeah. If there's any questions or anything, people can put it in the chat. Feel free. So for your protocol, you have a specific retinoblastoma leukocoria protocol, or is this kind of your kind of general brain and orbits protocol for everybody?
Oh, you have the same thing, right?
So you're doing the like the small field of view, SWI and DWI and stuff only in these specific cases, or is that kind of its own, or is that for all your orbits cases?
So I think like for the leukocoria, so T2 3D is a must, but I mean like sometimes because this patient we normally do them under general anesthesia and we normally do scan check. So when we see those things, and if the DWI of the brain can give you the better resolution for the tumor grading, we don't do the small field of view. But if we need like if that lesion is too small, we normally do like the thinner cut on the DWI, like a small field of view, like a 2 millimeter thickness, at least to improve the resolution of the images.
Yeah, no, I think it's it's definitely what we do. I don't think we don't add an MRA, but maybe we should.
So I think it depends, because like our neuro IR people are the one who request that thing, because they don't want to spend like a lot of radiation dose trying to find the ophthalmic artery. So they just want to, if this one has a normal anatomy, conventional anatomy of the ophthalmic arteries from the supracrinoid, they just go straight over there.
No, I mean, that makes sense. Yeah, definitely.
Yeah.
But any questions from out there in the Zoom land? No questions. Thank you so much again. Hopefully somebody can hopefully people will visit you in Thailand and go to that. You know, it seems like a great great opportunity. But yeah, thank you everybody, and thank you so much again, Tanya, for this, and yeah, have a great month. Hopefully see everybody next month.
Okay, thank you so much for having me. Thank you.
Thanks a lot.